Glad that we have an expert here today on gastrointestinal issues. Dr. Iturrino is a BIDMC gastroenterologist. She is also a professor and
Assistant professor
at Harvard Medical School in gastroenterology. She has a very impressive background, did her fellowship at the Mayo Clinic in Rochester, and has advanced training in motility issues in GI symptoms. So thank you so much, Dr. Iturrino, for being here today, and enjoy the presentation.
Thank you, everyone, for being here. I'm so glad to see patients and family coming to understand a little bit of what is going on with your GI symptoms. I will say that in my experience, the patients that have the knowledge about what is going on are more resilient, they understand better what is going with their body, and actually improve their quality of life, so empower them to be better. So I think that giving more information about what might be happening with you helps you in the long term. So I have no disclosures, of course. So today the objectives are what I would like to try to tell you is how common are GI disorders in Parkinson's disease, what are the most common GI disorders in Parkinson's disease that we encounter, especially in the clinic, and what are some treatment options. And at the end, of course, if you have a question and you want to ask something through the talk, feel free to ask me, and at the end we will have questions and answers as well, and I hope that I can answer your questions. So here you can see that GI disorders in Parkinson's disease are common. And if you see here, the 0 time over here is the time of diagnosis of Parkinson's disease. You can see that patients with Parkinson can start manifesting symptoms of GI symptoms, constipation, trouble swallowing, etc., even 12 years before the diagnosis, up to 30%. Then they get the diagnosis of Parkinson's, and through the next 5 years, it's a common, we call it the prevalence. It's very common, up to 80% of the patients can have GI disturbances. So the interesting point that I want to make today is that it can come even before the diagnosis. And why this happens? So we still don't understand well. We know that there is an accumulation of these misfold proteins that are deposited in the brain, and maybe the theory is, they are deposited in the brain in areas that affect the GI tract. And they're interesting. There is a new study in 2019, it's a rat model, and they showed that actually these proteins can come even from the GI tract, travel the layers of the cable that connects the intestine to the brain, and it gets deposited in the brain. This is in animal models, and we need to have more information about it, but maybe this can explain why you start having so much symptoms, GI symptoms, even before the diagnosis. Maybe there are some deposits also in the GI tract early on. So I want to present a case that I saw in the clinic. And he's a very pleasant 65-year-old gentleman that has constipation all his life. He managed his constipations with oral, with medications over the counter, did not help much. And then 2 years before the diagnosis of Parkinson's disease, his constipation got worse. And the constipation meaning he was straining more, he has the sensation of incomplete evacuation. That means that you go to the bathroom maybe every day, but you still have stool in the rectum. You feel that you cannot completely empty it. And this was causing more abdominal gas, abdominal bloating, distension. In the last year, after the diagnosis of Parkinson, he started experiencing problems swallowing, food getting stuck here in the food pipe, and also some regurgitation of food and acid and weight loss. So what are the most common GI disorders in patients with Parkinson's disease? One, and we're going to go through this in more detail, but one that is very common is weight loss. Other ones can be dysphagia. Dysphagia is that trouble swallowing. It can be initiation to swallow, or it can be like when you're starting to swallow, it can be when you pass to the food pipe or the esophagus. There is a common concern also that patients can have, that is something called dyspepsia. And dyspepsia means indigestion, that you eat and you feel bloated, you feel uncomfortable, you can have abdominal pain. Patients can have also dysmotility, meaning that the intestine is not moving well, predisposing patients to bacterial overgrowth, which are bacteria that are in the colon and they travel all the way to the small intestine. You start eating and cause bloating and discomfort because they're not supposed to be in the large intestines, they are in the small intestine. Constipation is extremely common, and today I'm going to talk a little bit more into deep constipation, and I want to show you about a condition called rectal evacuation disorders. And rectal evacuation disorders means that your pelvic floor muscles are not relaxing for the stool to come out. And that is one of the most common causes of constipation. And we actually see it in patients with Parkinson's disease, okay? So weight loss. All the way, like 50% of the patients with Parkinson's can have weight loss. And as you can see in the slide, it's multifactorial. It can be because they don't have appetite. You don't have appetite to eat, but it can be because you're having trouble swallowing and the food is kind of getting stuck. So you start to eat less or less quantity or different consistencies. It can be because you are nausea. You have nausea and I will go more into the causes of nausea. It can be because your intestine actually is not moving well, so it's taking longer to digest the food. Also, it can be because of different decreasing hormones like leptin that have been shown that increase weight loss. Or the energy requirements with the tremors or the muscle rigidity that you are burning more calories, among others. So dysphagia or trouble swallowing, it can be seen in 50 to 80% of the patients. And it can be start of swallow, like I said, oropharyngeal, because it goes from the mouth to the pharynx, or it can be esophageal. So the symptoms for oropharyngeal dysphagia are like when you start eating, then you start coughing, choking, you kind of choke with the food. And also you can have some drooling, like saliva comes out. It's like you feel that the food is not passing the tongue out or it's getting stuck very high up. So what we do is actually the ear, nose, and throat specialists are the one that really evaluate the upper part here. They usually do a video swallow study where that's a picture of a video swallow study. They give some contrast, and then they give you some foods with different consistencies, and they can see if that food is going to the wrong way, like to the lungs, or is taking stuck here, or if it's coming up. Okay, and or we can see if there is evidence of aspiration to the lungs. How we manage this? So while you are doing the video swallow study with the speech therapist, they are giving you different consistencies, and they are saying, oh, you see, if you eat this consistency, you will not aspirate. Or if you do this type of maneuver, the food will not come to the lungs. So it's a lot of physical therapy as well helps. Some people can have tied what we call an upper esophageal sphincter. It's kind of when you are swallowing and connecting to the esophagus, there is kind of a virtual sphincter there. It can be a little bit tight. Some people require Botox injections. If you have a bar or a muscle over there, some people need some type of surgery. Okay, so that's for the oropharyngeal part. We see it in the clinic, but then we work with Dr. Malur and the ENT group over here to treat the patients in common. Why this is not moving? Okay. Oh, there you go. Okay. So esophageal dysphagia is as common at 80% of the patients said, I think food kind of gets stuck, or I have some trouble swallowing. They can experience heartburn, regurgitation of acid or fluid or regurgitation of food. They can develop complain of chest pains and also weight loss, because trouble swallowing can cause weight loss. So this definitely can reduce the quality of life, and especially it can reduce the intake of medications, because if you feel that you're swallowing a pill and it's getting stuck, so you start not taking your medications, I suppose it can predispose to malnutrition and even to aspiration. So what studies we do? We do we call it a barium swallow, where you drink contrast and we can see how the esophagus looks, but we have a more specialized test. It's called the esophageal manometry study. In this institution, we have high resolution and looks something like that. We give you it's a catheter going down the nose, and then we see how the esophagus is contracting. Okay, it's supposed to come from above all the way to below. So it puts the food down. So this is a normal swallow here. You can see it's beautiful colors. I like the colors. It's beautiful swallow is coming down. And then what we see in early Parkinson's is or failed swallow. So here the liquid is staying in the esophagus and you're not seeing this nice red kind of purple coming down, or it's weak. Okay, we see that in early Parkinson. In more advanced Parkinson, we start seeing something like this. You see that's like a very big spasms, and that can cause more chest pains. There's another condition that we call EGJ outlet obstruction, meaning that you have a lower esophageal sphincter. As I told you, we have an upper one, so we have a lower one, and this one can be tight. So what happened is that it's not relaxing well. So we can see that also in patients with Parkinson's disease. So what is the treatment? So we do a lot of lifestyle modifications, starting with, let's see, soft food, drink water after eating. Important in the patients that they can crush pills instead of having the big pill, crushing the pills, taking with applesauce. Sometimes I ask, go to your pharmacy, see how many medications can be converted to liquid, or how many medications can be open. Take it with applesauce so it's easier, and then you ensure the absorption. This is important, and is that when you have these disorders of the esophagus, Parkinson's disease medications sometimes can cause a little bit of more constipation and adverse effect for the GI tract, but not for the esophagus. So if you are early on medications for Parkinson's disease, that can help your esophageal movement or peristalsis. And some people, as well as I told in oropharyngeal dysphagia, if your sphincter tone is too tight here, we can stretch, we can put injections, we can do Botox injections to help the food coming down. And there is a new drug. It's not such a new drug, but I will be talking about prucalopride in constipation. We use it in constipation. We use it in delayed gastric emptying. And there's a couple of studies that I have seen that might help with this weak peristalsis in the esophagus. So I'm thinking sometimes, maybe putting you in a medication that can help move everything can help improve the quality of life and nutrition, among others. But we need more studies for prucalopride and the esophagus. Otherwise, we don't have any medication to help move the things down to this up to date. We hope to have at some point. Nausea. Nausea is a very common symptom as well. The most common cause is because of side effects of dopaminergic medications such as levodopa. It can cause nausea. But if you have nausea and then you have indigestion, feeling full too quickly, you eat and you feel bloated, you vomit, it's not just the side effects of the medication. It can be something called dyspepsia or indigestion, or it can be delayed gastric emptying or gastroparesis. And that's where we need more evaluation. And how we diagnose this, we do a gastric emptying study where you eat an egg, and then we see how food is emptying the stomach, and I will show you a little bit more after. The difference between dyspepsia or indigestion and delayed gastric emptying, we can see it more in when we do a gastric emptying, because in dyspepsia, the gastric emptying is normal, but you have many symptoms. In delayed gastric emptying, so the food is staying longer than 4 hours in the stomach. And that helps us what type of medication we can give you. So dyspepsia usually happens because of lack of accommodation of the stomach. When the food comes in, the stomach is supposed to relax, but it's not relaxing, it's tight. So you eat and you are like, oh, I feel full. And then you can have, the recommendations is small frequent meals, low fat, and there are studies actually from our colleagues and our group showing that if you have less stress and especially better quality of sleep, the GI symptoms improve. So we always are asking, are you sleeping well? How is your stress? Because we know that it can affect and causes indigestion. So what medications we use for dyspepsia or indigestion? We use medications that have shown to accommodate the stomach, meaning from fasting, when you eat, relax. Iberogast is a herbal compound, many studies from Germany helps that it can help digestion, accommodation of the stomach, and then the other 3 medications are anti-anxiety, antidepressants that we use it in low doses to help the stomach, because there's plenty of studies showing, well, some studies showing that helps. Mirtazapine, or if you recognize Remeron, helps accommodation of the stomach and helps appetite as well. Buspar also is an anti-anxiety antidepressant that helps the accommodation, and nortriptyline, we usually use it more if pain is the major issue. Nortriptyline is a good drug. So this is how a gastric emptying looks. You take a scrambled egg that has radio label. We check at 0, at 30 minutes, at 60 minutes, and 120 minutes. And here is your stomach. We just put some lines. Oh, this looks like the stomach. So you can see exactly like that, yes. And you can see how this looks like a stomach and this looks like intestines, right? It's emptying, Here, maybe it's emptying too fast because at 4 hours there's nothing. But this is the one that is not emptying. You see how after 4 hours, after 120 minutes, the food is not going anywhere. These are the patients that then need a prokinetic medication, something to help push the food out. The message that one of the messages that I wanna explain here is that it's not by symptoms. You cannot go to the doctor and say, I have nausea, I have vomiting. Oh, you have delayed gastric emptying, or you have gastroparesis. No, we need actually to see what is going on, because if the gastric emptying is normal, it's different, but some of the things are different that how we're gonna treat you if it's abnormal, okay? So what are the symptoms? Again, nausea, feeling full, abdominal discomfort. You eat and you feel with pain, vomit, especially when you start seeing vomiting, weight loss. That brings a concern. And what happened with gastroparesis, imagine that if you put a pill in the stomach, a full pill for 4 hours, that's not gonna get absorbed. It's not gonna travel to the small intestine. So we really try to put liquid medications or crush the medications to make sure we absorb. Because if not, when we do an upper endoscopy, that pill is sitting in the stomach. So it's not helping you, right? So what is the treatment for gastroparesis? The treatment will be, and this seems basic, but I don't know why many people will not do it, is hydration and diet. Hydration, Pedialyte, I love Pedialyte. It's instead, you can drink water, but Pedialyte has the same electrolytes that we put in IV fluids. And a gastroparetic diet, it will involve more low fiber, like salads and all of that. Things can be very hard to digest for the stomach. For example, not cooked vegetables or raw vegetables are very hard also. So we try to do low fiber diet, low fat, blenderized food. Why? Because the stomach is like a blender. And if you blender the food, the chicken or the fruits or whatever you want, you blender and you take it to your stomach, the stomach seems to tolerate or absorb better. You are helping the stomach, right? So this is very important in the gastroparetic drugs, that is the prokinetics. Metoclopramide or Reglan cannot be given in any patient with Parkinson's disease. This is a very common medication that we give to help empty the stomach, but this is a central and peripheral dopamine receptor antagonist. So it goes to the dopamine receptors and block them, and that will exacerbate Parkinson's symptoms. But domperidone, that is a drug like Reglan, is only, the receptors are only not in the brain, are more peripherally, and that can be safely given to patients, but it's not approved in the US. We get it from Canada. We try not to use it if we don't need to, because it's not approved in the US. Erythromycin is like an antibiotic, and also is a prokinetic, meaning that it helps emptying the food, and it's okay also to use. We use for the nausea, anti-nausea medications such as dissolvable ondansetron or Zofran, suppositories for nausea like promethazine, Tigan, etc. And very important, if you're having a lot of symptoms here, upper, like your indigestion, delayed gastric emptying, we need to make sure you're not constipated. Because if you're constipated, imagine this kind of is a tube. If you're constipated, everything is going to back up. So you are going to have a lot of symptoms. So we need to make sure you are going to the bathroom emptying, so the food that is in the stomach and everything start moving, okay? So anyone wants to do any comment about this or have any questions about what we have just discussed?
Just one.
Yes.
Should all the medications just, as a preventive way, be crushed?
What I will do is go to the pharmacist, your pharmacist, and show your list and ask them which one can be crushed. Which ones can, and then she will tell, no, this can, because some medications cannot be crushed, and some medications have liquid formulation, so you can see if you can try to crush the most you can, but needs to be supervised by a pharmacist.
Like the most common one, of course, is Cinemet. So should Cinemet be swallowed whole or crushed?
So that's a question that I don't know. I think that's a question that it will be, you need to ask the pharmacist to make sure. Yeah, because we don't know their guidelines or which ones can be crushed or not. Yes?
I find that I can chew the cinnamon tablets anytime I want.
Okay.
The equivalent of crushing them, and they work just as well.
Okay.
They work faster, in fact.
Yeah. So good. And then then sometimes they give you something to crush it at home. But again, supervised by a pharmacist, okay? So constipation. Constipation can manifest very early on, 10 to 20 years before the onset of Parkinson's disease. And in this Denmark study of 30,000 people shows that people with constipation were at higher risk of developing Parkinson's compared to other cohort that they looked for. And actually the risk was almost 4 times as higher in men than in women, that it was 2 or 3 times as higher. So what are the symptoms of constipation? There's many of them. Is straining. You need to strain, you have difficulty with defecation, you have pellet stools, hard, you have sensation of incomplete evacuation, that the stool is staying there, that the stool cannot pass. You can feel bloating, fullness. So I just want to mention that feeling bloated is not all the time what the food that you ate. It can be constipation. And then having less than 3 bowel movements per week is also part of the definitions. And some people need to even use glycerin suppositories, enemas, or even put the finger inside the rectum to take out stool, and the woman sometimes inside the vagina to help expel the stool. So the most common ones are this one, you see, straining, hard loop, incomplete emptying, and then goes forward. So what are the causes of constipation in patients with Parkinson? So slow transit constipation, things are not moving so well, so we give laxative. It can be because of weak abdominal muscles to strain and to have a bowel movement. Or it can be because of a rectal evacuation disorder, or what we call dyssynergia. And I will go a little bit more into this, what it is. Other causes can be inadequate fluid or oil if you are not eating well, etc. If you are busy or it's hard to get to the bathroom, so you can ignore the urge to defecate. And if you ignore it, the body is very smart and it's going to say, done, we're not going to have a bowel movement now. So ignoring the urge is important. Inability to sit in on a commode or putting in a proper position for defecation. And of course, a lot of medications can cause constipation. The anticholinergics for the bladder, for salivation, the opioids like if you're in narcotics, calcium channel blockers, among others. So what are the subtypes of chronic constipation? So the most common is that the transit is normal, up to 60% of the patients, right? Then, following is rectal evacuation disorders, that the muscles are not relaxing. Then less likely is slow transit constipation. And then you can have a combination of slow transit constipation and a rectal evacuation disorder. So when do we need to further evaluate for rectal evacuation disorders? If you fail conservative management, that I will tell you about that in a minute, diet, laxative, over-the-counter medications, and if you need to still strain and have difficulty with defecation, then we evaluate for this condition. So I'm just going to show you what is the normal pelvic floor anatomy. So when you this is your pubis and the tailbone, right, over here. And this muscle here is a puborectalis muscle. That muscle wraps the rectum, is always tight because you don't want to go to the bathroom. And the anal sphincter that is here is always tight. That's the one that you can control. So when you go to the bathroom, that muscle, if you see it over here, this muscle relaxes, it opens, then the descent of the pelvic floor muscle and the anal sphincter relax. So what happens if you cannot relax this muscle or open the anal sphincter for defecation, the stool stays stuck in there. And that's what is a rectal evacuation disorder, which is common all the way to 30% of the patient with constipation. And we know that if you have a rectal evacuation disorder, up to 60% of the patient can develop slow transit constipation. And we know if we treat the pelvic floor, maybe some of the patients, the slow transit constipation improve. There can be also some structural disease, such as rectal prolapse, vaginal prolapse, bladder prolapse, that it can obstruct the defecation, causing a rectal evacuation disorder. How we evaluate this? With a rectal exam, we can measure how the pelvic floor muscles are working and the weakness of the muscles. And we do a high-resolution anorectal manometry, or we call it an arm test, where it's like the esophagus that we did, but we do it, it's a catheter in the rectum, and we can measure the pressures of the anal sphincter, and also how the rectum generates pressure as well. So we know what is going on in both sides. So what happened in a rectal evacuation disorder is that this sphincter, in Parkinson's disease actually mostly, the sphincter is not relaxing. So you are pushing, and this is not relaxing, right? And for example, in this study, there was 12 out of 19 patients newly diagnosed with Parkinson's disease had an abnormal anorectal manometry. But this is the caveat that 40% of them were not complaining of symptoms. So we need to, it goes by symptoms, by rectal exam, where we give you the diagnosis. And then this is another drug, this is another good news, that if you start levodopa, carbidopa early in Parkinson's disease, actually can help the anal sphincter and the paradoxical contractions that you're getting. The other test that we use to diagnose a rectal evacuation disorder, we do, if the patient has a CT scan, we can check for trapped gas. Patients with a rectal evacuation disorder has more gas in the rectum compared to patients with slow transit constipation. So this gives hints to us. And in some patients, if you feel that there's a rectal prolapse or is obstructing, or the bladder is coming down, the uterus is coming down, we do an MRI defecogram where we put gel in the sigmoid, and then we see actually with the MRI machine how you are expelling the contrast, and give us more information about where are your muscles if you're having more prolapse. Other studies that we do for slow transit constipation, this is the most common one. We do give you a pill full with rings, and it's called the SITS marker study. You take it, and then we follow with an X-ray in 5 days. And if you have less than 5 rings, then it's a normal transit. If you in 5 days have all the rings there, so we say this is a slow transit constipation. Other studies are for the gold standard. It will be a colon transit study, or a whole transit study is a scintigraphic study, it's a nuclear scan study. We don't have it in this institution, but we have one that is comparable that is called the SMART pill. And SMART pill can tell you the transit of your intestine as well. It's hard for the insurance to approve the SMART pill. We always have some issues. So what is the management of constipation? So first, we need to exclude red flags. What is that? Rectal bleeding, weight loss, family history of colon cancer, family history of polyps, bleeding, and also other secondary causes like you just started a medication and you started getting constipated. But if you exclude it, and you don't need to have the colonoscopy, or you had your colonoscopy, etc., what we ask you to do, what we recommend is conservative management. Important. In the morning, you eat your breakfast, 300, 400 calories. You drink something warm, like a coffee or a tea. You take your time to go to the bathroom. Whenever you feel the urge, you go. Because there is something called the gastrocolic reflex, and that happens just a couple of times a day. And you need calories in your stomach to induce that gastrocolic that usually happen in the morning. So then we ask you to increase some fiber, etc. If there's no response, then we go to bulking agents. Bulking agents mean Metamucil, Citrusel, Fibercom, Benafiber, all of that just to help put in more fiber that possibly in the American diet we don't have. If you fail that, then we go to, you can see 4 types of medications here. We have the osmotic laxatives. And what is that? You put some sugars in the colon, or anions that are not absorbed, like magnesium citrate, milk of magnesia, Miralax, lactulose. All of that things are called osmotic laxative, and it's going to drive water to the colon. The other group, other family of laxative is the stimulant laxative, which causes more increase in contractions, like Bisacodyl or Dulcolax laxative, not stool softener. There's 2 different. Senna, all of that are stimulant laxatives. Then we go to a newer prescription medication drugs that we use, and are the chloride channel or sodium exchanger medications. And these are newer drugs, and I'm just going to mention the names so you know. Lubiprostone is the same as Amitiza. Linaclotide is the same as Linces. Plecanatide, tenapanor is more in the newer side. And then we have the prokinetics medications that move everything, and that's the prucalopride that I was telling you, and tegaserod. These prucalopride and tegaserod are 5-HT4 serotonin agonists. That means serotonin is all the way in the enteric nervous system, in the GI tract, and it stimulates the serotonin receptors, so it improves motility all the way down. Prucalopride is a complete agonist, but tegaserod is a partial agonist. And tegaserod was in the market long time ago, and it was removed from the market because it was causing some heart issues. It came back. It's back in the market now. I have not used it because we have the prucalopride, but just to mention that is back. If you don't have response, so you can use you can check for rectal evacuation disorders, you can combine agents, you can check for other things. The couple of more slides that I have left is to show you how the medications work, depending on the subtype of the constipation that you have. So if you see fiber supplementation it helps constipation, but in which type of patients? In the patients that have normal transit constipation, fiber is gonna help. But if you have slow transit constipation, look at this, no effect, or maybe some improvement. So that's why we need to personalize who is who, what is going to be your regimen. If for rectal evacuation disorders, fiber can help, but then not completely, etc. The osmotic laxative, I talk about them, I like Miralax, I like magnesium oxide or milk of magnesia if you don't have kidney disease or heart disease. It helps. I use one or Miralax, or you are in magnesium, and we can use it in combination with fiber. So that is a simple regimen over the counter that helps the patient moving things. I try to avoid lactulose because it's a little bit harsh to the stomach. So Miralax, as you can see, improve bowel movements up to 6 months in patients with constipation, 52% improvement compared to 11%. So it helps. Bisacodyl, that this is Dulcolax, also in 4 weeks, there is a marked improvement compared to placebo. But the problem with the Dulcolax laxative, it can cause diarrhea, abdominal pain, and some people stop it. Sometimes I use it like a rescue therapy. So I'm taking like Miralax with fiber or magnesium with fiber, and if you haven't gone to the bathroom in 5 days, so then you can do a Dulcolax laxative, 2 pills at bedtime. So you have kind of a regimen that you can follow to help you evacuate. And these are the newest chloride channel activators, like I told you, that what they do is they go to chloride channels in the layer of the colon, and then it drives more water. Amitiza helps, a dose of 24 twice a day compared to placebo in 4 weeks, as well as linaclotide. And there is a new study that I saw in patients with Parkinson disease that they compare linces or linaclotide with prucalopride, and both were good. Both were tolerated for patients with Parkinson's. If you had constipation only, linces was a very good, or linaclotide was the drug. But if you have upper GI symptoms, then prucalopride will be the drug for you. And the major problem with the linces is that it causes diarrhea in up to 20% of the patients. So that's why before we had 2 doses, now we have a 3rd dose that is a lower dose, 72, 150, and 290, because it causes diarrhea in 20% of the patient. This one, the Lubiprostone, Amitiza, is a good drug as well, but causes nausea. So if you have nausea, so maybe it's not the drug for you. At the end, all of these drugs, the chloride channels, work the same. The important is which one is good for you depends on the side effects that you're able to tolerate, or how are your bowel movement with this type of drugs. And this is the prucalopride that is safe. 6 randomized controlled trials showed 28% compared to 13% improvement as well. And it can cause some headache. So people that have migraines, I try not to do it or start at very low dose. So for physical therapy, for rectal evacuation disorder, what is the treatment? Actually, it's physical therapy. Once we diagnose you that you have trouble defecating, physical therapy. It's called biofeedback, and head-to-head studies show that biofeedback is better than taking Miralax. Biofeedback is better than putting Botox in the rectum, in the anal sphincter, etc., or that better than usual care. So what they do in biofeedback, once you're diagnosed with a rectal evacuation disorder, you are with a physical therapy. We have a great group here, and then also I refer patients locally. They put a catheter in the rectum, and as you see, there's type of troubles of dyssynergia, but here's an example of one patient. So the patient is not generating rectal pressure. So when you are squeezing, when you want to press, the rectum is not moving much. It's not forcing. But the anal sphincter, this down here, is tight. So it's not doing anything here, and this is tight. after physical therapy, you can see how the rectal pressure is beginning to come and the anal sphincter is not contracting so forcefully. And then here, at the end of the treatment, the rectal pressure is better and the anal sphincter is relaxing. So that's what we do, that's why it's called biofeedback, because they give you some things to do and then you learn by using a device called EMG. So in conclusion, for constipation, particularly dyssynergic defecation or rectal evacuation disorder, is very common in patients that fail conservative management or laxative in patients with constipation. So it should be addressed because we do physical therapy for it. We need to do more tests if the laxative are not improving symptoms. There's plenty of drugs that we use, be fiber, the laxative, the chloride channels, secretagogues, and prokinetics, and biofeedback can be considered. So back to the patient that I was referring at the beginning. So the weight loss of the patient was multifactorial. He was having trouble swallowing, not eating well. He was having constipation. So he saw the nutritionist. He started with more soft stool, water intake, chewing well the food, etc. We did evaluation for problem swallowing, and he had weak peristalsis. We managed also an evaluation for rectal evacuation disorder, and then we did physical therapy. And because he was having more generalized GI symptoms, we started him in prucalopride, which is one of the drugs that we have available, as I told you. So in a nutshell, it's important to recognize who are you, how are your symptoms, talk to your doctors about your symptoms to see what other things we can give you. It's not all side effects of medications. There's other conditions that are related to the Parkinson disease that can cause your symptoms. And I hope I can answer any question. Thank you.